Well, good afternoon, ladies and gentlemen. I think we'll get started. Welcome to the Woodrow Wilson Center. My name's Jeff DeBelko. I have the very good fortune of coordinating our Global Health Initiative, directing our Environmental Change and Security Program. So it gives me and it gives the center great pleasure to be hosting today's session that we've entitled, Is Universal Access to Family Planning a Realistic Goal for Sub-Saharan Africa? This event, like so many of the ones we've done on these topics, have been done in partnership. And first and foremost, Amy Choi and her colleagues at Johns Hopkins University have just been invaluable partners in really making this session possible. Without them, it would be absolutely impossible. And so we thank them for what has been a continued partnership and a rich partnership in advancing these issues. Duff Gillespie is somebody who really got our program started back in the 90s, and so it's terrific to see him here as well, now sitting out at Hopkins as well. So it is it's a great pleasure to be working with Hopkins again. And then that same USAID Office of Population and Reproductive Health that Duff was working in continues to be very supportive of the work that we're doing. And so this session today is under our HELPS project, Health, Environment, Livelihoods, Population, and Security, trying to bring these issues together. And obviously, as we're talking about family planning in Sub-Saharan Africa, a range of these challenges come together. It is the work that we're doing here at the center, allow me just a word about the center, which is trying to bring some of these different communities together on a nonpartisan, non-advocacy basis, and honor the legacy of Wilson, who was our only president to have a PhD, and bring the worlds of scholarship and policy together. And as you can see, we have a panel of distinguished scholars who are very active in the policy realm. And so they themselves in this panel reflect exactly that objective, to bring these worlds together and have a constructive dialogue. Our Environmental Change and Security Program has been working on these issues of population health, development, environment since 1994, and it's terrific that we're able to continue with today's discussion in the line of ones that we've had in that forum. We are broadcasting the event live on the web, which I'll urge the folks watching online, you can see follow along with the PowerPoint slides if you access them there on the web page. But what that means for us here in the room is really just when it comes time for the question and answer, if you could wait for one of my colleagues to bring you a microphone, then the folks online can hear what you have to say. And folks online, if you'd like to get a question into the discussion, email it early in the meeting to ecsp@wilsoncenter.org. We'll try to get that question into the mix. We're very fortunate today to have as our guide and moderator Dr. Michael Mbizvo, who is the Director of Reproductive Health and Research at the World Health Organization. As you can see in the bios that you picked up along with the participants list, Michael, as well as all our speakers, has a distinguished career looking at very specifically these issues. And so we are very pleased that he is willing to play this role as expert guide through discussion. And so I will turn the floor over now to him. Michael, please, the floor is yours. Thank you, sir.
Thank you very much, Jeff. Good afternoon, colleagues. Let me add my thanks to all of you for taking time to join in what really should be an exciting discussion today. The question before us is a very good question. The question before us is universal access to family planning a real goal for Sub-Saharan Africa? If we're talking of universal access, we are talking of equitable access. We're talking of uptake of services, usage of services. We're talking of coverage of those services. That certainly the services are appropriate, they are affordable, they are accessible, they are of good quality. And if so, what enables those services to have those attributes? And if there is problems that relates to access, what are the barriers? There are issues that need to be taken into account. in terms of some of the interventions and strategies which have been used to ensure that there could be universal access to family planning. Before us, we have distinguished panelists, and each of the panelists is going to share some of the studies they have done, including giving examples. We know that if we're talking of universal access per se, we're really talking of something that requires us to go into detail, which would really take quite a bit of time to identify and say, as far as the situation in Africa is concerned, what is it that we require if we are going to ensure universal access to family planning? So the best we can do is really to share developments that are either country-specific or district-specific or are actually topic-specific. And certainly we can draw lessons and extrapolate. And it is this we are going to be sharing today with the first presentation, which is going to be given by my colleague, Frederick Makumbi, who is currently a senior lecturer and head of Department of Epidemiology and Biostatistics at the School of Public Health, College of Health Sciences, Makerere University, Kampala. Frederick trained as an epidemiologist and statistician and demographer, receiving both his master's and PhD degrees from the Johns Hopkins Bloomberg School of Public Health in 2000 and 2004, respectively. His research focuses on the demographic impacts of HIV/AIDS, including infant and child mortality, orphanhood, and adolescent sexual behaviors, as well as having strong research interests in reproductive health, especially amongst HIV-infected population. His recent work on fertility and HIV infection includes two landmark publications: The Association between HIV Antiretroviral Therapy and Prevalence and Incidence of Pregnancy in Rekai, Uganda. I think quite a few of us have heard of Rekai, and certainly it is a place where a number of flagship cutting-edge studies have come out. His other study is on the use of HIV-related services and modern contraception among women of reproductive age. Welcome, Frederick, and thank you for taking the floor.
Thank you very much for this opportunity, and everybody who has come to listen and discuss these presentations. Okay. Thank you very much. As indicated, my topic is as shown, and I come from Makerere University, School of Public Health, as well as doing a lot of work with Rakai Health Sciences Program, where these data are drawn for this presentation. Fertility in Sub-Saharan Africa is very high. However, contraceptive use is low, and Uganda is one of the countries with very high fertility rates in Sub-Saharan Africa, as shown by those data. And quite a number of factors are driving this high fertility, including unmet need for family planning, as well as lack of male involvement in this. We know that HIV has had a lot of impact on the fertility, but this has been felt a little more in the individual level than the population level. This is quite crowded. However, contraceptive use, contraceptive knowledge is quite universal in a Ugandan setting. However, uptake is low. About 18% are using modern contraceptive methods, but this has been increasing over time. However, contraceptive use is low among HIV-positive women, as shown by those studies. And the data that we just looked on the publications I mentioned, we are seeing an increasing pregnancy rates in HIV-positive women who are in care, suggesting that there is need possibly to promote contraceptive use for those who need it. And also this tells us that there's a need to potentially integrate family planning services into HIV care services as well, in order to address the need among people who need it. Therefore, in this presentation, I share some findings on fertility preferences in the Rakai setting. Rakai district is located in southwestern part of the country, And although it's been out of development over time, but typically communities look exactly as shown. The Rakai cohort, where this data are obtained, is been running for over 20 years in about 50 villages. And on average, we are seeing about 15,000 people annually in this cohort, giving interviews for those who consent, including collecting information on contraceptive use, fertility, and of course, biological samples for HIV testing and other STIs. And quite a number of studies have been nested in this cohort. A number of activities are done prior to collecting information in the fields, including mobilization, health education, and as well as sample collection when the teams visit the communities, as indicated in those pictures. One of the first studies we did in 1994 during the STD control trial of HIV prevention, we had some findings on pregnancy rates and incidence in the Rakai community, looking at HIV positive and negative, and these were quite high, really. However, again, the HIV positive, the pregnancy rates among HIV positive were lower than the negative, and these data have been published. But also incidence among HIV positive women, incidence of pregnancy was also lower than those who were negative or not infected. Almost 10 years down the road, we looked at HIV prevalence among women, positive women, who are in HIV care or in ERT, or who seek and get enrolled in HIV AIDS care services. What we see here that before women initiate ART, the prevalence of HIV is lower than when they have initiated ART. This is true across all age groups. Again, the same data, we went ahead and looked at the pregnancy incidence among HIV-positive women, again, who are in HIV care. Clearly, we are seeing an increasing incidence of pregnancy when women come into care or initiate on ART, more specifically. And of course, then this suggests that there is a need for more attention for reproductive health needs, including family planning among HIV-positive individuals. Not that they should not become pregnant, but should they have a need, there is need to look at that issue. Again, looking at the cohort now, not only among HIV positive only, looking at among HIV positive, we try to look at other factors that may be influencing the desire of fertility among these HIV positive women seeking care. And one of the factors that we are seeing there is males' partner fertility desires. When males' desire is high, we tend to see higher incidences of pregnancy, irrespective of whether women have initiated ART yet or they have not yet initiated ART. Again, the population we looked at among women who want to stop or postpone the next birth in Rakai. And one thing we see here is that HIV-positive women tend to be using family planning method more than the HIV negative. But again, the need of family planning, this proportion not using, the negative tend not to use compared to the positive, but also the married have a gap compared to the unmarried, suggesting need possibly for family planning in these communities. Again, we compared the trends or the changes in family planning use in Rakai over a period of almost 10 years. And we realized one thing, that there's been an increase in use of family planning over years in this cohort, irrespective of HIV status. Again, we went ahead and looked more critically for women who are in HIV care. We tried to appreciate and see the various two methods that are used for contraceptive, condoms only as well as other modern methods. What we see here, condom use is increasing with increasing level of care. These are not yet enrolled in care. These are in care but not yet on ART. These are initiated in ART. So we are seeing an increasing trend, whether married or not married. However, one other thing we see, condoms tend to be higher than the other contraceptive methods. And one other important point to note is other methods, which includes injectables and hormonal contraceptives, tend to decrease with increasing level of care among the married women. Other results not displayed here are clear that large family size, desire for large family sizes is still a very important factor, and these data have been shown in the publications as indicated on these slides. We also looked at receipt of voluntary counseling and testing. We realized it's associated with the higher use of condoms in this setting. The interesting thing, again, we noted is VCT, receipt of voluntary counseling and testing, without discussing your results with a partner, was associated with higher use of modern methods, but not condoms. In summary, condom use is more common among unmarried positive women, but not other modern contraceptives. Also, we see that condom use among positive women increases, and protection by other contraceptives decrease with increasing level of care. So being in care has an effect on what method people are using. Summary, unmet need for family planning is still high, especially among married women. Use of family planning has significantly increased over time. We saw over a 10-year period. Being in HIV care, we have realized also significantly increases use of family planning, especially condoms over other methods. What are some of the things that we may need to think about based on the findings we are seeing in these results, at least for program people or policy guidelines? We suggest strategies that would address the desire for high fertility, because that is still still playing a very big role in this setting. So these strategies need to be either developed or strengthened. And one of the issues we have seen is male involvement, where males need more, desire more. We tend to see higher fertilities. And there's need to strengthen family planning services in HIV care programs. As we have seen, with increasing level of care, we are seeing increasing condom use, but other contraceptive methods seem to be coming down. So we need to pay extra attention to that as we do our programs in this environment. I acknowledge the colleagues and the funders for these various studies and the Guest Institute, which has enabled us to be here in this meeting. But also, importantly, I can't forget the cohort participants who provide this data that we can be able to analyze and plan and develop appropriate programs and services for them. Thank you very much for listening.
Thank you very much, Fred. Certainly, one can see and take home a few messages. And what we'll try to do is to discuss at the end of the panel presentations and get contributions from the floor. But it's always very interesting in that if you look in unplanned pregnancy, very often just looking at the women who present for preventing mother-to-child transmission, the rates in the second pregnancy for unplanned pregnancy tended to be much higher, partly a reflection that there was no discussion of their family planning needs. So here we are talking of expression of choice. And certainly from this paper you can see that family planning, which if we define it in the context of universal access, where everyone with a similar need has equal access, you can see that expression of choice. The very empowering aspect of family planning is the ability to be able to express your reproductive choice. Colleagues, we would move to the second presentation, which is going to be given by my colleague, Oladoso Onjenbegde, who is a specialist obstetrician, gynecologist, from the University of Ibadan. He was appointed a professor in 1992 and served as provost of the College of Medicine from 1994 to 1998, acting vice-chancellor of the University of Ibadan from 1995 to 1996. He is currently participating in cutting-edge research, which has positively impacted on maternal and child health globally. He was the co-principal investigator of the multi-center trial on the use of non-pneumatic anti-shock garment, which is a novel life-saving device for hemorrhage. This trial has influenced new policy guidelines for managing postpartum hemorrhage internationally. It has also facilitated the introduction of emergency obstetric and neonatal care in Nigeria. As a renowned international fistula surgeon, he has mentored and provided leadership for dissemination of this skill in the country. He has completed many projects externally funded by the international organizations, including the Bill and Melinda Gates Institute for Population and Reproductive Health at Johns Hopkins University. This award led to the establishment of the Center for Population and Reproductive Health at the university, to which he is currently director. So thank you, Ola. Welcome.
Okay, good afternoon, distinguished ladies and gentlemen. Let me start by also appreciating the privilege given to us to be before you on this topic, which actually is a question which says, is universal access to family planning a desired goal, a real goal for Sub-Saharan and Africa? And I think we should be able to go away with an answer to that question from this afternoon's presentation. So I'm going to start my topic with an answer, my personal answer. And the answer is a great yes. But the question now is, if universal access must be for development and growth of people of Sub-Saharan Africa, where has it not been? And the first thing I would like to say is that one of the major issues are that the people who are eminently placed to make this happen themselves, including policymakers, the people themselves, community leaders, perhaps are not well informed enough. Because to do what is right, they need to know what is true. The first thing is that one of the bane of poor maternal health services in Sub-Saharan Africa is the insensitivity to the population explosion by all. And indeed, when you talk about family planning, people tend to see it in Sub-Saharan Africa as some form of subjugation, attempt to decrease and shrink the population of Sub-Saharan Africa, which they view to be an asset in terms of numbers, not so much putting emphasis or the necessary emphasis on quality along with numbers. And one of the major issues that has been able to propel and sustain that feeling is the sociocultural and religious barriers and interpretations of marital bliss, in that it is seen as for procreation and not for partnership and enjoyment. Also, this has been a flaring effect of the triage of poverty, ignorance, and disease that has mitigated against the uptake of family planning in Sub-Saharan Africa. This is a slide that shows, obviously, that over the years, this is showing uptake CPR between 1989 and 2005. And you can see that in most of Sub-Saharan African countries, it's just not rising. For, I think this is for Kenya, it's plateaued. For a country, Nigeria, which has about a quarter of the population of Sub-Saharan Africa, the CPR is still very low. And this is the open circle is for Nigeria. And over the last years, between 1998 and 2003, it seems, in fact, to have flattened out rather than increasing. So obviously, we have a great challenge concerning uptake of contraceptives and family planning in Sub-Saharan Africa. Now, the ripple effect of this can be seen in every area of development. So there has been failure of sustainable development in all fronts of human endeavor, including health, and nutrition, even the environment, as a result of the large and so unsustainable population. And obviously, it has impacted negatively on all indices of human development. This is an example I mentioned about Nigeria. For instance, if you look at higher fertility projection in Nigeria and estimate the number of primary school students to be enrolled. The bottom one, the blue line, shows that this is using the current fertility rate of 5.7. If we were to use a low fertility rate for Nigeria at the current population of 140 million, by 2040, we would only have 36 million people of primary school enrollment age. Whereas if we don't do anything, by that same year, we will have 58 million. Obviously, currently, we are not even able to handle what we have. 58 million children in a single country of primary school age is like putting about 4 countries or 5 countries in Europe together. So what this does show is that, in fact, if we do have uptake of family planning such that by 2040, the enrollment will be 36 million, that will still be a great challenge to any of the sub-Saharan African countries, including Nigeria. Also, there's a poor commitment to women's health in sub-Saharan Africa, as shown by all the indices, including maternal mortality, maternal morbidity, and so on. This slide shows that that sub-Saharan Africa has the highest level of maternal mortality in the whole world, of 640 deaths per 100,000 live births. And the one below shows permanent income per quintile per country, which also shows the effect of the high population rate on income rates, and therefore this will impact negatively on individual and family and community health and wealth. High unmet needs for family planning is prevalent in all countries of sub-Saharan Africa, and it's a major root cause of the poor maternal health indices. This shows that in sub-Saharan Africa, the total, if we look at the total, the use of modern contraceptive method is only 16%. And 5% are for those who are using traditional methods, which do not have evidence-based for its effectiveness and efficacy. But if you disaggregate these to the regions, you find that, in fact, where you may have some good effect is in Southern Africa, perhaps because of the presence of countries that are more advanced than the others, like South Africa. Nigeria, for instance, where I come from, is in West Africa, and you can see that the average CPR is 8%. which is absolutely very low. Again, Mike did mention about universal access means equitable access to family planning in terms of accessibility and quality. This graph also, bar chart, shows that the poor women have the least access to family planning. And this is showing the family planning use among the wealthiest and the poorest women in Sub-Saharan Africa. Again, if you look at the total, only 10% as opposed to 31%. Again, if you disaggregate it, it's more encouraging in Southern Africa, but in all the regions, the poor women in Western Africa, only 4% of them have access to family planning. So the question then is, what can we do if the answer I gave is correct? What are we going to do? What can we do? We know that the CPR rate is very low. We have evidence to show some of the causes of this low CPR leading to population explosion. We mentioned that traditional religious and practices and beliefs is very strong in Sub-Saharan Africa, and people at community level hold on to this. One of the areas we are beginning to focus on is strong advocacy to change these beliefs and traditions by using the traditional rulers, especially in the northern part of the country. And we've been able to start off a very strong engagement with these traditional rulers. This, for instance, I'm sure you can see Henry Mosley from the Gates Institute, has been facilitated by a partnership program between the University of Ibadan, my Center for Population and Reproductive Health, and the Gates Institute, in which we invited and engaged the traditional rulers to understand that they occupy a critical position to make things change in a positive direction in their communities and at the national level. And in fact, they are well placed to also influence policy, since also they are not just respected by community members, but by the government structure in most of Sub-Saharan African countries. This shows a map of Nigeria showing percentage distribution of women with short birth intervals, 7 months to 23 months. The key point here is that in the white shows the ones with the highest proportion of shorter interval, and the deep brown are the ones where the interval between births is very short. Most of the health indices and development indices in Nigeria tend to follow this graph in the sense that maternal mortality is worse in all these areas where the birth interval is very short, income is also equally low, and level of female education is very low. And the maternal mortality and neonatal and infant mortality is highest in all the regions, especially in the Northwest, where you have most of the states. So it does look like, one, trends in development indices and the health indices tend to follow the practice or uptake of contraceptive practices and family planning. So what has been the secret of the success we're achieving with the traditional rulers to make this change at community level and at national level? We have been able, like I said at the beginning, to do what is right, you need to know what is true. We have been able to counsel them and educate them by using hard facts that they are ordinarily not aware of. And indeed, when we show them some of the things happening within their communities, they see it with great disbelief. And once they understand that, you are able to give them the facts, evidence to show that indeed what you are talking to them about can have positive effect on the health of their people, they then understand and are able to become great champions and partners. Making them to discover they are key players for family planning awareness and promotion and uptake, at community and in family level, educating them that family health leads to family wealth, because ordinarily, most people in Sub-Saharan Africa are not able to relate family planning with family and individual health and wealth. They only see it in terms of population control. And so there's a disconnect in their understanding, and that may inform their resistance to approving the use of family planning methods. Also letting them, therefore, that the household is primary producer of health and assisting them to navigate towards providing solutions by themselves. This group of emirs who are representing a large, about more than half of the states in Nigeria that were engaged both in Nigeria and in Baltimore recently, were able by themselves to have a statement of commitment. And at the recent National Family Planning Conference in Nigeria, the representative of the spiritual head of the emirs and the Islamic Nigerian community, the Sultan of Sokoto, did stand up to say family planning will be the first time we see a traditional ruler use the word family planning. Is very good for the health of the woman and the family, and that it should be encouraged at both family level and at community level. And to us, that is a very big stride already, with such statements coming from such a highly placed traditional ruler. So what are some of the things we feel can improve the use and uptake of family planning towards improving the health and wealth of individuals and the family? At macro level, the strategies will include generating and sustaining momentum of government commitment in the sub-region. Either follow some of the agreements that have already been in place, the Maputo Plan of Action, and much more, because indeed most of the governments do not appropriate or budget adequate funding for reproductive health, let alone family planning as a subset. Also to legislate support to women's autonomy to be able to take decisions on matters concerning their health and other issues, especially the use of family planning, and helping to implement policies to improve the quality of counseling and access to childbearing. Recently, we found that most of the women after delivery do not receive, as used to be in years past, the routine family planning counseling that goes with postpartum care. So there are missed opportunities within the health system. And also to encourage family life education programs and sexuality education, especially for the young ones and adolescents. At micro level, strategies that will break the barriers of socio-cultural inhibitions, for instance, using the emirs and other traditional structures that are strong enough to help break the barrier, integrating family planning services into all RH programs, including all HIV programs, which I think is very weak in most African countries. People are running parallel programs. The money for HIV is only for HIV. And indeed, you find that for those who require family planning, I don't know about Uganda, you find there's a disconnect between getting them to access the services they require, because most of the PMCCT programs do not have a strong family planning component. To reinvigorate immediate postpartum contraception programs to avert challenges of default, and to accelerate female empowerment programs. This has been very strong now. It's coming very strong in Nigeria with engaging the traditional rulers and the policymakers, especially the governors. Female girl child education in the northern part of Nigeria is like a revolution in the last 5 years. And so it's gathering momentum, but we know that the effect of all of that may not be quite obvious until in years to come. And for now, in most of those northwestern and northeastern states, there are government bursaries for female students to go through primary, secondary, and even university. And many of them sometimes, especially those who are in what they call hardship areas like engineering, like medicine, are actually given some additional stipend apart from their fees being paid to be able to complete their education. And finally, to actively engage males in FP access and uptake. There have been missed opportunities that I did mention some of this before. The Nigerian DHFs of 2008 did show that of the women who were not using family planning in the 12 months before the survey, 4% of them were visited by a health provider who discussed family planning. Just 4%. The others never did. And of the same women, only 13% of them, of those who visited the facility, health facility, had family planning discussed with them by the provider. So there are great opportunities to gather the momentum for uptake of family planning, which are being missed. 92% of women neither discuss family planning with any field worker nor with any staff at any facility whatsoever. But I think the work must involve a multi-sectorial partnership of all agencies, development partners, the developing world funding agencies, but strong community component. And I think this is important because these are the end users. They're the ones who decide what they want to do. We only help them to decide. Faith communities which have strong influence on Africans' population, elected officials in politics and in governance, the business people, both organized and non-organized private sector, who could help mobilize internal resources, in-country resources, rather than depend on external resources for sustenance of commodities. Community leaders, parents, and also schools. We can take advantage of our peculiarities to improve access to IEC and uptake through just any method that we think will work. And we begin to think of using, for instance, in a peculiar situation in Nigeria, the use of police checkpoints for distribution of non-prescriptive commodities like the male condom. You never know it works. Enlisting retired health professionals within their communities as advocates for family planning, and maybe using them in non-orthodox areas like in marketplaces to set up on the side where women can access family planning services. The marketplace is a big attraction, a gathering place for women in Sub-Saharan Africa. We need evidence and we need to continue to collect data and to disseminate the data that is available. In conclusion, FP accessibility must be through a multi-pronged approach that should be colored with socio-cultural sensitivity, solid evidence that is available, and a sustainable mechanism. Certainly, FP's success in Sub-Saharan Africa is a must for the region's sustainable development. The postal is, will the situation for this young girl who potters, doesn't know what the future perhaps holds, will it be the same as it has been with her mom, with several kids in a polygynous family setting, not accessing, not able to pay for services, and not be helped to achieve the optimum health that she desires? Well, African proverb says the best time to plant a tree will be yesterday. The next best is today. So if we have had missed opportunities, I think we should start now to improve it. Thank you so much.
Thank you very much, Ola, for triggering the revolution which you talked about. Certainly that the momentum needs to be maintained, whether it's advocacy with traditional leaders. You have also correlated very well the development indices to sexual and reproductive health progress, in particular use of family planning. the fact that they do follow each other, these indices, to really look at this as an issue of not just health, but also equally development. And I would add the issue of rights, the right to family planning. I would like to invite our third speaker, who is my colleague, Frank Towler, who is a senior lecturer and acting head of the Obstetrics and Gynae Department and director of the Center for Reproductive Health at the University College of Medicine, Malawi. Frank received his medical training in the UK and Malawi, and his master's in public health from Johns Hopkins Bloomberg School of Public Health, and is a fellow of obstetricians, gynecologists, South Africa. He is also currently president of the Association of Obstetricians and Gynecologists of Malawi and chairman of the National Maternal Death Audit Committee. His research program focuses on sexual and reproductive health-related research activities which are funded by the Gates Institute for Population, Family Federation of Finland, WHO, and the Netherlands government, the University of Pennsylvania, and Columbia University. He is also an investigator of records in the ACTG studies, mainly funded by NIH in collaboration with the School of Public Health and University of Malawi. Dr. Towler is also a leading national advocate and trainer in family planning and a consultant to one of the principal family planning organizations in Malawi, which is an affiliate of Marie Stopes International and a member of the National Sexual and Reproductive Health Task Working Group. Welcome, Frank. Thank you.
Right. Thank you very much. My first thanks should go to the Gates, our colleagues at Johns Hopkins School of Public Health, for giving us this opportunity to come and share with you some of our work and experiences in our countries, and for me, it's Malawi. And also, I should thank my colleagues and friends on the partnership which Gates has actually initiated, and also thanks to the organizers of this, this meeting. What I'm going to share with you this afternoon is just some of the experiences and some of the practicalities and programs and interventions which a country as Malawi, Ministry of Health, and its partners, which College of Medicine is part of it, we've been going through. And maybe a little bit of a background before I give the actual layout of my presentation. Malawi as a country, we got independent in 1964. And one thing I remember very well coming to the Johns Hopkins, every time I meet a student, particularly from USA, they'll ask you, where's Malawi? I hope all of us here, we know where Malawi is. And 1964, our population was just under 3 million. And from that year up to the late 80s and early 90s, there was no such a thing as family planning in Malawi. It was never, ever mentioned, and our leadership didn't want to talk about it. And since then, our population has grown. At this point, we're at about 14 million. The layout of my presentation, as you've seen, I'm going to talk about the background, the fertility preferences in our country, and what are some of the factors which sort of are hindering the progress of family planning programs, challenges, strides, and then the way forward as we talk about the unmet need in the country. This is just a background that you should know in terms of figures of total fertility rates. We're looking at 6 as a country, but that varies from the urban to the rural. As you can see, for the urban is at 4 and the rural 6.1. This is from the DHS of 2004, and also some of the latest studies which have been done in the country. We just done the 2010 DHS, and I'm keeping my fingers crossed to see better figures than what we are seeing here in terms of the reduction of these figures. And some of the influencing factors in terms of the disparity between the urban and the rural areas, issues of socioeconomic status, level of education, the infrastructure, and cultural and some of our religious beliefs as well, which are prevailing in the society. In terms of the contraceptive factors, sorry for the typo there, is that one of the facts which we know very well is that our commodities in terms of the methods, in terms of the budgeting, very much dependent, on the donor. And in the rural areas, sometimes there are difficulties in having a method mix. Often you tend to find that maybe there's one or two methods, which makes it very difficult for women to have a proper choice in what they want. And issues about inadequacies in staffing levels at the rural areas, and also dispensing centers as well in those areas do play a part. In terms of our contraceptive prevalence rates, that is also from the previous surveillance which has been done, we're at the figure of 38%, that is of modern methods, and the 3% for the traditional methods. So we're looking at a 41% picture of the CPR. And I expect that they should be much higher than this now. We did a study together with our colleagues at the Gates Institute, and one of the areas, but this was more for a very urban area. And actually the population which we had, that was a couple study, the number of couples who were taking a method were much, much higher than these figures. In terms of the fertility preferences, this is looking at the years 1992 to 2004, that in 1992, 65% of married women did not want to have another child or wanted one in the next 2 years, looking at the 35% of unmet need. And as the years progressed to 2004, you can see that actually the needs in terms of unmet need was much lower than that. And in our efforts, we're trying to bring that figure to a lower level. And here we're just looking also, continue with the fertility preferences in the same particular year, that unmet need for spacing is higher among younger women, which I think you can have various ideas why is that. Well, unmet need for limiting is higher among older women. And although the overall demand for contraception is lowest among the adolescent women, the percentage of demand that is satisfied is also lowest in this age group, which is around 75%. So what are the contributing factors to this high level of unmet need for family planning in Malawi? I've given a few here which we can discuss as we go into the discussion time, but we look at the existing misconceptions and myths about family planning. I'll give you an example of this. The most commonly taken method in my country, Malawi, is the Depo-Provera, the depo-medroxyprogesterone acetate. And often we know what we call as providers, health providers, an advantage. That is amenorrhea, which comes after you start taking the method. The people in the villages, they don't look at it that way. They think it's a side effect. They believe that where is this blood going? It might be accumulating somewhere. So you find that some women are not happy to take that because they think there's a lot of bad blood which is circulating in their systems. The other factor also which could be attributing to this high unmet need, the stockhouse of various methods, particularly in the rural areas. Access to facilities is also another challenge, particularly when it comes to the rainy season, when bridges or roads are not accessible to couples in the various areas in the rural areas. And also another big area which is quite a concern to some of the places where these methods are available, is the health worker there, the attitudes which they have towards their clientele. Issues about religion. I know my colleague in Nigeria, when you take a look at Nigeria up north and south, very much two different groupings there. In Malawi, it's predominantly, a Christian grouping, but we have quite a high percentage of Catholic community, and we know very well issues pertaining to family planning. And also issues about the role of other family members, maybe what been on the method, and some of the experiences which they had with those methods. So in terms of challenges in addressing this unmet need, what are the issues? Shortages of trained professionals in this area. We see that a lot of posts or services or centers, they're very much concentrated in the urban and peri-urban areas. But our population is mainly rural. About 75% of the Malawi population is in the rural areas. Issues about insufficient funding for family planning programs, as I said before, that is very much dependent on the donor community. And also the point which my colleague Dosu mentioned, failure for people to link, the connectivity or the benefits of family planning and the country's development. Those are also some of the issues, and political stability as well. And issues about short-term versus long-term gains. I think these are some of the areas which, we are battling with. A very interesting bill which was tabled in Malawi about 2 years ago, trying to up age at which our young girls should get married. It was moving from 15 to 16. And the interesting thing about this bill, it was the reaction which came from the community. It was passed in Parliament, waiting for the president to assent to that bill. And because there was a lot of noise which was made, the president hasn't put a signature to that. Then what does that entail? It means we're still at 14. I mean, it's okay to get married at the age of 14. And since those 2 years, Parliament has met so many times, but this bill has never been tabled. And the consensus in the country is that it should be up to about maybe 21 of age. But since that time, nothing has happened, meaning that it's okay in Malawi at the age of 14 to get married. And these are some of the challenges which we're facing. This is a very interesting but sad story. This is a mother who was divorced, left with 4 kids. The reason for that divorce is that she ended up having triplets. And the boy here, the firstborn, and we are told that they never intended to have another pregnancy. But what had happened that stockouts at a facility in the rural area, and then when they were told at the antenatal visits that actually they are triplets, there was commotion in the family, and when they were born, the man disappeared. These are realities, these are real issues, and this woman is actually alone. And for those who are very much interested in nutrition, you can see already, just looking at the hair, that these kids are malnourished. I brought up this because I tend to use this quite a lot when I discuss issues with members of parliament, politicians, and policymakers. We need to start understanding our population, the population pyramid, and what it means. And if you look at this, you can see that the Malawi population is very much of young people. And a lot of these young people are not even generating an income. And the burden of these young people on the economy of the country is massive. We have what we call free primary school education, meaning that the small population which is earning and contributing an income or in form of taxation to the country is very small. In essence, what does this entail? It means the pay as you earn by the end of the month is quite massive. Meaning the population of Malawi, because of this young population, very dependent population on a very small percentage of people who are working, cannot manage to survive the end of the month because all the money is going into this government programs to sustain this young population. So what strides have we put in place, or what is it that has been happening in trying to address this challenge of unmet need in Malawi? At the Ministry of Health level, there are a lot of things or programs which are happening, targeting the rural masses, because that's where the greatest need and challenge is. For years, Malawi, we have used the community-based distributing agents in the rural areas, and these they do door-to-door distribution of some of the family planning methods. Normally they take condoms, combined, and progesterone-only pills to the population, and also messages to the communities of the importance of using family planning methods. And the training or trainings to this grouping of people has increased in all the rural areas, so that we can try to reach out to at least 70% of those at need. Of late, some colleagues of mine working with USAID can also testify to this. We have gone in another phase. In addition to the use of CBDAs, we're now engaging the health surveillance assistants. They're given training and selected areas whereby they are now providing Depo-Provera at the rural level. So you can see the combination of these two groups widen the coverage, and also different type of methods which are going to be applicable. One of the areas which, as a country, Malawi is doing quite well, and this is a point of, some people call it task shifting, some people call it task sharing, is the use of our nurses in the provision of what we call long-term methods. When I was a medical student, the insertions of implants were mainly done by young doctors and also ICDs, but now that service has been given to nurses. They are able to provide this, and a lot of women are coming and taking up these services. The programs of youth-friendly services have been intensified, because we're seeing a lot of teenage pregnancies and also early marriages as well. So targeting these young people in the rural areas is also another important project which is taking place in the country. It's not only government which is working hard in this area of family planning provision, but also there is a public-private partnership as well. We do have this big organization, we call it BLM, and this grouping has done fantastic work in Malawi. And the interesting thing about this grouping is that it has gone right in the rural areas where they provide a service. Not for free, but we see that the uptake is also quite high, because one of the things people enjoy is that the services which are provided there is not only family planning, but also STIs, and now they have embarked on the HIV program as well. The other interesting area, which is quite new in the country, this grouping as well is doing, which I think has done quite a lot in increasing the uptake of family planning commodities, is that they have identified some, privately owned clinics in the rural areas. These are clinics who have been run by retired midwives, clinic officers working in the rural areas, who are just running their clinic, just providing services to issues of malaria and other common ailments in their areas. So what this organization has done has gone into those areas and to say, can we add family planning as part of your service delivery? So there's a partnership of these small clinics in the rural areas, and the BLM do provide the commodities which can be available to the people in the rural areas. And I think this has been a great partnership and is having a lot of spin-offs. Other institutions like my College of Medicine, where I work myself, were also fully involved and engaged in this area of assisting government in trying to reduce the percentage of that unmet need. As my colleague from Nigeria, Dosu, mentioned, we see the importance of having engaging the community leaders. And as our organization, Center for Reproductive Health, we've been having discussions with the leadership and also the traditional leaders and also those custodians of various denominations in the country. And the other level we have gone is engaging the members of parliament. We had about 2 sessions last year. We had a combined males and females. And then this year we engaged the female members of parliament, about 20 who came. And one of the topics we had discussed with them was about family planning, the importance of it, and what's their role in the parliament. And one of the things which came up there after we had discussed with them that we've been following the deliberations, we see that women members of parliament, they tend to be on the side of men, hardly talk about issues affecting women. And we're trying to say you're there on behalf of the women of Malawi. It's high time that you have to put a priority to issues which are affecting women, and I think family planning is a very critical area because of an increase in the maternal mortality ratio in our country. Also a critical area which we have focused in our organization is to look at the role of the media, and we have trained them for over the years in areas of health issues, issue reporting, and of late we engage them in the activities, importance, and the role family planning plays in the economic development of a nation. And this year we've seen quite an intensified, deliberate reporting on the issues of family planning, method by method, and some of the challenges which the country is facing. So, the way forward. We have lots of challenges, but I think also lots of achievements. I think there is need as a country to have, ownership to this program. What do I mean by that? I think we have to lobby the policymakers that they take this as a serious thing to their own benefit and also the benefit of a country in terms of increasing funding in terms of family planning programs in Malawi. And also another area which is very critical, I don't think you can only look at this targeting one ministry or one organization, but I think there should be a deliberate move towards targeting the girl child in Malawi. I think time has come whereby we have to focus on this girl child, make sure that we keep her in school, make sure after school goes to high school and tertiary education, because I think education is also another family planning product. I always tell this to my students in school and say, how come you're 22, but you're not pregnant? So I say, the fact that you're listening to me now, that is a contraceptive agent on its own. So being in school many years, I think will prevent some unnecessary, unwanted pregnancies. And also at a national level, we're looking at promoting the welfare of women. I think it's very critical that women should be seen to taking a leading role than playing a back seat. And also we are targeting the influential women in society. I think it's very critical. And as I said, the role of female members of parliament, I think that's also critical. I think we have to continue lobbying and try to speed up this marriage bill amendment. Of now, there's nothing much done. I think we have to continue discussing with the authorities of trying to push this bill back on the agenda. Issues about cultural and religious beliefs, we have started already looking at this. Some of the cultural practices which affect negatively on the uptake of family planning, as we discuss with our traditional leaders. The promotion of public-private partnerships, I think this has to be encouraged and promoted. And also the expansion of door-to-door family planning service delivery at community level, I think we need to encourage this. So yes, indeed, I think we can eliminate this unmet need for family planning in Malawi as we put our heads together, our thoughts together, and our energies together to fight this high percentage of unmet need for family planning in Malawi. Thank you very much for your attention.
Thank you very much, Frank, for bringing in quite a few elements which are important here. You have brought in the dimension of maternal mortality, the contribution of unintended or unwanted or unplanned pregnancies to maternal mortality, and also the issue of having quite a few challenges alongside achievements, where each time we have a step forward, we can at least look and say what have been the challenges and see if we can draw lessons from the challenges we have encountered. I think there are a number of issues, a number of take-home messages that have come up, and we'll get into those. But before summarizing, we would like to open this very rich discussion, open this to the floor. If there are contributions, if there are questions, if there are recommendations. I think I would like to underscore the critical issue here of what it is we can do if we are to achieve universal access to family planning in Sub-Saharan Africa. So please feel free to make recommendations which you think would need to be added to the array of contributions we have received from the speakers. I would invite the speakers to take the floor, and what we can do is take at least 3 at a time, and then they can respond. So colleagues, the floor is open. If you can, please identify yourself and where you're coming from so that we know who is with us.
Good afternoon, ladies and gentlemen. My name is Rosemary Segero. I'm the president of Hope for Tomorrow. Hope for Tomorrow focuses on empowering women and young people through microfinance. Thank you so much, African gentlemen. It's good listening to you and coming up as African men to talk about family planning. As you know, African men is not easy to get into family planning because they all want children, they all want, but I'm so happy that you came in, and my advice or my encouragement to all what you spoke was development, empowering women. You know, this empowering women, education and empowering women and young people is one of the family planning, because people get, when people are doing nothing, they intend to go and sleep, and the only thing that is in their mind is sex, and not only sex, children. So an African man, you'll never convince him unless you have a child from him. So what I think would be encouraged is getting, as you all spoke about, door-to-door training, schools and whatever, encourage this as a celebrate to the Department of Education. This to be in education from grassroots, from elementary, high school, up to the university, because these are young, not only girls. Young men are there who are African men who want children. Young girls are there. So let's put it inclusion into as a syllabus in schools, so that from daycare to university, everybody know that family planning is there. And while we are doing that, we want to empower people. Give them jobs, give them education, and empower us, because everybody wants to be busy. When people are busy, their minds will not turn to activities, sex and pregnancy. So I think Mr. The World Health Organization, Nigeria, Africa is Africa. So we just need that. So in next time you put a pill, I'm here, I'm based here in Washington, D.C., though our offices are also in Kenya. So we are all in Africa, and thank you so much for coming, but put it as empowering young people, women. This is what will be the most effective family planning. Even if you inject me, like the HIV, you talked about HIV. How are they using condoms? And you know very well, contraceptives, and you know very well they have HIV/AIDS. Even using condom is something else. Using family planning, because they are not safe. They are already having HIV. So let's work out and see to empower, to educate young people, to empower them, and make people more, productive into empowering themselves than just sitting idly, children. And I'm just so happy, though there's no woman, but I'm happy your message has been heard in Africa and all over the world.
Thank you very much. Yes, sir. Okay.
Okay.
All right. After you, number 2.
Thank you very much, members of the panel. I'm Kaidi Jadunwola. I'm from Obafemi Awolowo University, Ile-Ife, Nigeria. One comment and one quick question. Listening to all the presenters, you've reiterated the seeming cause for these large unmet needs for family planning in sub-Saharan African countries, from the demand side and from the supply side perspectives. One thing I didn't hear coming from the supply side perspective is the issue of contraceptive logistic management system. Everybody talks about stockouts. I know more than 10 years ago, the issue of contraceptive logistic management used to be very high up an issue in development. John Snow International and UNFPA used to organize regional and national courses on contraceptive logistics. But nobody hears anybody talk about those things anymore. And the central stores in Uganda, where Frank is from, used to be a model store that everybody used to go and visit to know how contraceptive logistics can be handled. But I'm sure if we go back to this issue of stockouts, we can handle better than we're doing now. My quick question to Frank was that during your presentation, we found out that there was increased both prevalence and incidence rates of pregnancies among patients that are on antiretroviral therapy compared with people, HIV positive patients that were not on antiretroviral therapy. I was wondering whether you ever gave it a thought what could be the cause of this. My suspicion is that it could be as a result of the counseling that we give women who are on ARTs. We always ask people who are positive not to be pregnant until they commence drugs and have near zero viral loads. Whereas the people who are not on drugs, we always advise not to get pregnant. I wouldn't know whether this might be the reason for this. Thank you.
Thank you. Yes, sir.
Cha-Chen, freelance correspondent, Basis of Maryland. Thank you for your comment. I have some question. First is to Dr. Towler. What's the implementation of the counseling? And also about this, how about the after birth health care? And that in the beginning you show that fail to connect FP to the economic development and the political stability. Dr. Ojembikde have said that FP lead to the health and lead to the wealth. Do you think this also applied to in your country? And also the same question to Dr. Fankirby and Dr. Ojembikde in Uganda and Nigeria, respectively. Thank you.
Thank you. Why don't we take those 3 questions and we can come back again to the floor. Who is going to start?
Thank you very much for the Thank you very much for the questions. I'll start with the ART issue that women who, HIV positive women who are in care, more specifically who are on ART, tend to have increased incidence of pregnancy compared to those who are not in care. When we are doing these analyses, we initially thought that when HIV positive people get into care, there's improved health. Sexual activity increases. There's that line of thought. 2, when they get into care, especially ART, viral loads go down, CD4 is improved, and yet we know viral loads increased viral loads associated with spontaneous abortions. So when they're on care, viral loads go down, CD4 go up, improved health, so we tend to see an increased incidence of pregnancy. So some of the things we are looking at, this data that we analyzed where we didn't have sufficient numbers, but there are suggestions that could be either a social issue, it could be biological. But also when women become healthier and they are men, then one other thing we see that they tend to go back to fulfill their desires, family-sized desires. Also that plays a significant role. So is it a biological, is it a social factor? It's not yet so clear. Various studies have been conducted, but it's not clear. However, we go ahead and women are given counseling for both family planning and HIV. They are not asked not to become pregnant. They are counseled and they make an informed decision. Of course, giving them both sides that of the consequences of becoming pregnant when they are positive. So that I think that could be one of the reasons we're seeing increased pregnancies because of improving health.
The first, my response is to the first issue about logistics. The logistics and commodity security is woeful, like you observed, but that's simply because the policy has not attached much to family planning commodities or to family planning. So you don't put your money where your heart is. You put your money where your heart is. And it's only now that we are reawakening interest and commitment to family planning that the issue of commodity availability and security at all times to ensure access at all times has become paramount to governments in Sub-Saharan Africa. We have, perhaps you know, we have Gates partners from various institutions, and we have partners meeting. And one of the things we talked about during the presentation today was that in Nigeria, for instance, with a renewed initiative to improve family planning uptake, a very strong mechanism is being put in place to ensure that commodities are available all the time, forecasting, purchasing, signing MOU with agencies that can help to ensure that commodities come in as at when due. So all of these are rolled up together. It's like a cycle. Okay, if you don't think something is important, you don't invest money on it. But now, as things change and evidence is available, I think the governments will begin to change and have already changed. An issue about family planning and being a development issue, of course, yes. The simple way we let people see those who are not in health-related professions like traditional rulers, community members, is the same quantity of food for 2 people. Okay? If you make it available for 5 people, they're going to have less. And Frank did show the lady, unfortunate situation here, no income, 5 kids or 4 kids, to feed. So obviously, even for the same man, for the same income, once the family size increases, the share per person decreases. So it's a question of family planning helps if you are able to determine the number you can adequately cater for. It helps to improve the wealth and the health of every family member, both the one that was born and perhaps the one that is yet to be born. Okay. I think I made the point. Okay.
Thank you. Just a quick one on Coyote. When you asked about the HIV and grouping on ARTs and pregnancy, I'll just say a little bit of the experiences we have in Malawi, of the studies we do in the AIDS clinical trials group network. We noted that we are actually having an increase of women in that cohort of HIV positive on ARTs. And one of the things we're trying to tease out is find out what exactly is going on. And we discovered that there was an issue of stigma. The point that in the communities, they see a couple not having children, they started talking to say, they're scared. They must be HIV positive. So try to run away from that to prove to the society that they're not HIV positive when actually they are. They thought pregnancy was an answer to that community. It was a small grouping, but I think the result was very interesting. On logistics, it's a critical thing. I will give you an example. I guess my colleagues who have worked in Malawi can also help me on this one. It's quite interesting. You know, our central medical stores in Malawi, there's a lot we need to do because that's a mother body in acquisition, distribution of medical supplies and drugs. But when you look at the family planning commodities, there is also another area which is also a concern. In Malawi, a majority of women can look at a percentage of 40% of users. They prefer to use what we call depot. And we had situations whereby we had lots of IUCDs, other commodities just, you know, stuck up in facilities. The point, if I remember well, we had to do a transfer to one of the African countries, I think Kenya, of the IUCDs. So also there's at program level and also at the user level. I'm connecting this to your question. You talked about issues about counseling. It has been a concern not only to me, but a lot of us providers in the country that, you know, these methods, there's a lot of technology. They're quite fancy things in terms of the mechanism of work, what is contained in there, what are the beneficial effects other than non-contraceptive effects, their side effects and all that. If you want to be a good counselor, you need to know all those things. Then you find that at the end of the day, most of the people who are giving these methods, they might have limited understanding of these, you know, methods, and that does play a part in terms of the uptake as well. And also the other thing, you find that even the provider has got already biased preference to a method that we have seen does play a part as well. The numbers of women coming to get methods also is another issue as well. You've got more, you try to find a method which is easier to give with limited counseling. And that does affect the uptake as well. Because you can imagine if 20 women come and 10 of them on an IUCD, you start thinking, you know, I need to have a pack, I need to have a place where I can do this. It takes longer. The same thing with Jadel. All those things do play a part. After birth care, you did mention that. That's another critical area. There are percentages. For example, they say about 93% of the pregnant mothers in Malawi, they do attend antenatal clinic at least once during their time of pregnancy, but only about 53 of them will deliver at a health facility, meaning the 47 that deliver at home. What are the chances of this woman who has failed to deliver at health center, delivered at a village, will be able to go and get care after the delivery? That also does pose a big challenge to us. There are reasons why they don't go back. You can think about them, I know them. But I'm just trying to explain to you that after birth care is also another area. If we increase, we improve in terms of the delivery of that commodity or service, yes, indeed, we might see an increase in the uptake, because that's the time when you can start discussing issues of family planning to these women who have just delivered, even the men who have just come with their wives to various facilities. Thank you.
Thank you. My name is Doyin Oluwole, Director of Africa's Health in 2010. Thank you for the presentations. I think I have 2 comments and 1 quick question. The first comment deals with your recommendation to generate and sustain commitment in the region. And you specifically mentioned the African Union. I just want to say that in the history of whether it's OAU or African Union, we have never seen the level of commitment that we're seeing today with respect to women's health, and in particular, maternal health, maternal and child health. Apart from launching the campaign for accelerated reduction of maternal mortality in Africa, There is also the Maputo Plan of Action, which you rightly mentioned. And as we speak, the African Union is preparing to have a meeting next week where they are bringing together experts in the region to actually harmonize indicators that would hold countries accountable for women's health, family planning, maternal health, newborn health, child health. I say this so that those who might not be aware that these steps are being taken can all rally round. It's a very small department of social affairs, but a lot is going on. And all hands just need to be on deck, because if a body like this arises and begins on an annual basis to hold governments, ministers of health, accountable for the health of their women, then we're beginning to get a big breakthrough. The second comment is to acknowledge what you are all doing involving MPs and the media, traditional leaders, and so on. And I'm pleased to say that we have a publication that will be of immense use to you in your countries. It's called Toolkit for Repositioning Family Planning, and it targets different audiences, including the ones that you talked about. We'll be delighted to ship some to your institutions, or if you are staying longer, we could give them to you before you go. Before I sit down, I have a quick question for the moderator. In 2005, there were publications that linked use of hormone-based contraceptives to increased mortality in women who are HIV positive and even increased viral load. I just need to know whether WHO has clarified this. Where are we with this? Because at that point, the decision was the benefits of family planning outweigh this disadvantage. So let's get on and just use it. Is there a change?
Hi, thank you. My name is Marissa Milmars, and I work on a project called the Global Leaders Council for Reproductive Health. And we're working on informing key decision makers and highest level policy makers of the centrality of reproductive health and family planning to a number of other development issues. And we're really lucky to be working with Dr. Mbizvo on some of this work. And we have a few opportunities coming up, including the World Health Assembly and the African Union Summit, to make some of these arguments to ministers of health, heads of state. And so I'm wondering, what kind of messages do you think your leaders, MPs, ministers of health, heads of state need to hear to make reproductive health and family planning more of a priority? Thank you.
I am Peter Ogunjigwe from Wafema University, Nigeria. I have one quick question for Professor Ojengwede on the use of this orthodox means to reach, to improve access. You know the background we are coming from when you are saying that we should use the police and all these retired people. I know the retired people, they are already tired. Then when you talk of police, you know these are the people that we even convert these things to some other means. When you give them these things to distribute at checkpoints, you know what they will do with all the, you know. How effective are all these methods? Because you are talking of orthodox means. I know we need to look for means to at least to improve access, but we have to be careful. Then another issue is the issue of this contraceptive prevalence, the figure we have been quoting for some of these African countries. There was a case of this advocacy on condom usage in Nigeria one time. You know, they brought condoms, plenty, shipload. Then there was infighting between one or two ministries over who will take delivery of that particular condom. Because of that, the thing expired on the, I think, right there on the sea. Then another issue with the usage of condom is that many of those people that do claim that they are using method, are they really using method? Do we do monitoring and evaluation? Do we find out that because many people will collect condom or whatever, all these other means from different sources, they will go, They will just throw the thing away and you believe that they are using. When we are quoting, we are including all these people in the figures that we are quoting. So I'm just saying this, that we have to be careful of the figures that we are quoting. For Nigeria, we are saying the usage of contraceptive is 8%. Are we sure it's 8%? Is it up to 8%? So we have to listen to somebody.
Thank you. Right there, yes.
I'm Foluke Ojalabi from Population Action International. I'm a fellow. And I want to thank all the presenters before I make my comment. My comment is actually for Professor Jengbede. And I'm glad that there's involvement of men and the community leaders in the North. But I was born there, I live there, and I've worked there in reproductive health. And I think the elderly women actually need to be involved more than the men. Because a young girl doesn't want to get married, but the women are saying, you can't continue staying in the house. So there's need to involve the older women in the advocacy. Thank you.
Thank you very much. We'll revert to the panel and come back again to the floor. We can do it in the same order.
Okay. Yeah. Well, quickly, I'll quickly respond to the issue of contraceptive use among HIV positive, but it was meant for you. But when I saw, based on these results, that there was a declining uptake of modern contraceptives other than condoms by women who are HIV positive as the level of care increased, I quickly ran to check out some literature. And from the same study area, a piece of research has been done which has shown that there is no effect of hormonal contraceptive on either on increased mortality among HIV positive women or progression to AIDS. And even another one has just gotten out. I forget who the author is. So at the moment, I don't know what WHO is going to recommend, but based on the two recent publications I've seen, one from, again, this setting, there's no reason to believe that hormonal contraceptives offer an increased risk in progression to AIDS or to adult mortality among these HIV-affected women who use them.
Thank you.
Okay, maybe I should start from the last one that refers to me. You see, in Africa, there's a proverb that says, when you have trees fall upon themselves, you store that the smartly it by picking the bottom one. You pick the top one first. There are many factors that affect the uptake of family planning. The issue about women, older women, is very important, but you see, their own views are also influenced by these custodians of traditions and culture. So those are the ones you need to break down first, and the others will become easier. If you start with those who are below, it's at various levels, they are not going to get anywhere because they will still be under the influence of a higher level influence, okay? But I agree with you. As many people, as many sectors that can be useful, you see, I showed the wheel of partnership. Everybody, schools, teachers. And that takes me to Peter's comments. What we were suggesting is we should be creative with the way we look at contraceptive distribution or access to health. I don't think we should kind of be restricted in our thinking. What we are trying to say is we should explore. Actually, that point is to let us know that we should explore creative ways. You know that some of the reasons some of the women don't access health is the time when we provide services in government hospitals is not suitable for them. They're in the market in the morning. Antenatal clinic is in the morning. No woman is going to come to the clinic. Most of the ones who come to teaching hospitals are the working class people. So, but the women who are at higher risk don't come because that program doesn't just suit them. Now, majority of Nigerian women or African women are even when they don't have to buy from the market, they go to see their colleagues. They go and buy something today, buy something tomorrow. It's a means of socialization in some sense. And it could be an opportunity for us as part of community-based distribution of services. If you look at it in terms of police, the police are distributed, checkpoints are everywhere, okay? They collect from you, but they can also give to you. They collect from you, but they can give to you non-prescriptive, non-medical contraceptives. Now, if a man does not come, takes a condom from you, a male condom from you, he intends to use it. Okay, at the partners meeting, our partners meeting, we were provided with samples. Those samples disappeared. They are going to be used. They are not going to be sold. They are going to be used. If you get what I mean. Whether the man who gives it to you or who is distributing it gives it to you to use, or he gives it to somebody else to use, or he uses it himself or to his friend, all we want is it's used by somebody who is in need. And since one of the major barriers is the access to having those things, we just want to use as many methods as possible to rapidly upskill access to family planning commodities.
Thank you. I'm a father of one 16-year-old daughter, and I come from a huge family. I've got 12 siblings. So whatever I discuss is from my personal experiences. What I've gone through from this big family. You know, we had to fight for a bed. 4 boys in there. I remember there was one bed at one point in time, so you had to eat quickly, make sure you get a good place in bed, otherwise you sleep on the floor. So I do what I do because of the experiences of the past. And the reason I'm sharing this is the question which came right at the back. What's her name again?
The lady.
Yes. I agree with you. As we target the traditional leaders, I've also noted that what we call the aunts in the villages, you know, the elderly women, they play a major part in influencing issues, you know, regarding their daughters and their nieces in the homes. Because I had that experience as well. She's 16. People think I'm still young, but I don't think I am. But the pressure my wife was getting from the aunt and the women in there, when is another one coming? When is another one coming? Not from the men, but from the women in the locality. So we should not forget about that as well. To go to the other question, you know, what messages, that was your question, we should be giving to these members of parliament who are coming to various, you know, forums. I agree with you. We need to sit down, put our messages across to them, which we have already started doing. And a couple of issues we discussed with our members of parliament is to say, look, time has come, you have to fight for fellow women in parliament. The numbers have increased in our country, but often the agendas which are there, they're only for the betterment of men. They have to see it that way. The other thing we also discussed with them in view of challenges women are facing, we said to them, if you have to look across the globe and look at countries in terms of development, it's very difficult to find countries, particularly on the continent, which is doing quite well, whereby its women are regarded as subordinates. So if we want to develop, if Malawi needs to develop, at the hub of that development, we need a well-informed, a well-educated, and a well-protected woman. And I said the way to go back through this is the women to work together than supporting the men. Because last year, there was a very heated political thing. A man or men said, time is not yet ripe for this country to have a woman president. And all the women said nothing. I don't think this is right. I wish the women would come and say, this is an insult to the women population in the country. So the point I'm trying to say here, I think we need to open up to the realities of our globe, our continent, and the women should open up to realize that they hold the key to development, and they're very critical in terms of their families, their communities, and also for the country as well. I think it's high time that in our region, I think men need to give or hand over power to women in terms of areas of policy making, funds allocation, and also of education, and all sorts of benefits which are actually only going to the majority of the men in our society. Thank you.
Thank you very much. Just to add in terms of the HIV, whether there is an association with incidence and family planning, I think one of the largest studies was done by WHO and FHI, multi-center study, a cohort study, in fact, looking at various methods, including non-users or IUD users, just to see if there was an increased incidence, and certainly the data did not support that. But we are constantly looking out. You may also have seen, I don't know how many have seen the BMJ study that came 2 weeks ago on the benefits of family planning to health. It came 2 weeks ago. It's one of the largest studies. I think it's a cohort of about, what, 40,000. And so over time, just looking at family planning, I could share that study. Yeah. I think it's worth visiting. They looked at various health outcomes, comparing those that used contraceptive methods that used family planning to non-users in terms of incidence of various health outcomes. And apparently, interestingly, whether it was heart disease, whether it was cancer, in the group that had used family planning, the morbidity and mortality was actually much less. Very interesting study. It does show an unexpected protective effect, and I think it's worth visiting. I saw that study, and a number of people have started sending and sharing copies of that study, just to say nobody expected that you could see this long-term benefit of family planning use. I don't know if we still have questions or we need to wind. Jeff, we need to wind. Okay, I think this has really been a very rich discussion. I will not try to summarize issues which have come up. Certainly a number of things, take-home messages have emerged. I was just reminded, in fact, by that picture of the family and the mother who did not actually intend to have a pregnancy and ended up with triplets, and the men deserted her. That really is one of the saddest realities. I actually remember when I was a student. I was a student working with a physiology professor, and in his study, he was looking at malnutrition. And we were going around farms. Amongst the farmers were the richest within the population, and yet the farm workers were the poorest, and they had lots of problems when it comes to having adequate food from beginning of the month to end of the month. And my professor had an interest, and we were measuring amongst the kids skin folds, arm circumferences, height for weight. And I actually remember one message. I mean, many of these women had quite a number of children, and the largest proportion of them were undernourished. And I actually remember getting to one mother, and she asked me what I had come for. And I'd said, we are assessing nutritional status amongst your children. And she just looked at me and said, I don't understand you. You know, this is my 7th child, and I thought you're coming to talk to us about family planning. That really became a take-home message. It had never occurred to me that the need could be in family planning, that she had no access to family planning. I had come because of the need to look at the nutritional status. And that really is the reality, and that resonates with the message we saw. I also thought I should share a message which I shared with colleagues just a few days ago, which is a quotation here which reflects on the reality on the ground by the Director for Reproductive Health in Kenya. I saw this when I was reading the monthly publication, Health Kenya, where she said, if a woman comes and misses contraceptives of her choice at our hospitals, even if they are brought in later, it does not make a difference. The next time she comes, it will be when a traditional birth attendant sends her to us, dying from complications of an unplanned pregnancy. It really means she would have made a choice, and she would like to have that method which works for her. And she goes and she does not find that method, and she gets disappointed. There is a stock out. She wanted to express her choice. She felt she had the right to family planning. She felt she could also access the means to make her decide. But unfortunately, we would tell her, sorry, if you want the injection, or sorry, if you want this one, you'll have to come next time because we have run out. And that also resonates with the messages that have come from the audience in terms of ensuring that our logistics, our management systems are functioning. But certainly from what we have heard from the panel, I think what I have heard is that the answer is yes. Universal access to family planning is achievable in Sub-Saharan Africa. But if we are to achieve it, there are a number of challenges to address. And there are also a number of strategies to adopt. And I think we need to work together, whether it is with traditional leaders, the private sector, the various systems, including the school system. We have heard that the girl child is pivotal, that if you are able to engage the girl child and give her the education she requires, that does empower her in terms of determining and making her own fertility choices. And certainly we can allude to that with evidence. We have done a 24-country, multi-country global survey on maternal deliveries, just looking at deliveries amongst 300,000 deliveries. Amongst those deliveries, we've documented maternal deaths, we've documented morbidities, we've documented quite a number of things. And we can look and say these are the immediate causes of maternal mortality in a 24-country multi-center study. But two key determinants, if you look and go into the data in terms of determinants, is the education of the woman. The education of the woman is a key determinant, as well as her parity. So these are some of the things which reflect on the need to look at the context and not wait until we suffer, until we realize the outcomes, but to really go back and work with the communities, work with the systems, sensitize politicians, sensitize the media, get them to talk about these issues of rights. In some parts, yes, CPR is flat, and we need to address and say what is it that can trigger the CPR to go up. The need to talk language that resonates with politicians, to see it as a development issue, to show the health indices alongside wealthy indices, so that it's not seen as population control. There is that we avoid the backlash each time of people assuming and being suspicious because they think there is something behind it, but really to get them to identify the need for family planning as an issue that is critical to development. to argue and ensure that there could be budget line items for family planning. Certainly, we are happy when we see donors support family planning, but we also need to get it in place within national plans and budgeting so that it's not just the disease outcomes like malaria, tuberculosis, HIV, but also issues of family planning. In fact, some countries have been innovative, have been able to put a budget line item for family planning within proposals to the Global Fund. And there is a decision point by the technical review panel of the Global Fund, the current discussion to include, the language is taking time. They are using now maternal, newborn, and child health and strengthen the linkages. My colleague did allude to the need to avoid the competition to actually strengthen the integration between sexual and reproductive health and issues of HIV interventions. And we can be innovative and support countries to come up with proposals where outcomes relate to both issues in family planning, issues in reproductive health, as well as issues in HIV and AIDS. Because the way it rotates, it is all part of issues or all part of us accepting that this is about sexuality, it is about reproduction. We cannot divorce, we cannot relate, we cannot disassociate HIV, for instance, from issues of sexuality. I've also seen and heard the message here of partnerships, multi-sectorial partnerships where we bring in key players. The marketplace, for instance, as a place where very often stories are shared and strategies are made. And in fact, in one of the studies I did a long time ago, just looking at whether men were supportive of family planning, quite a few women actually said when they go to the river, to the well to fetch water, that's when they talk of family planning. And in fact, they shared. One would bring a packet, and they shared that packet of family planning each time they met in the morning at the family planning well. So let me take this time to really thank our panel and request that we give a big hand, not just to the panel, but also to Johns Hopkins School of Public Health, the Gates Institute, which has brought us together to come and share some of these issues. Let's really give them a very big hand. And let this be partnerships amongst ourselves and say to those women in Africa, we are there to support you, achieve universal access to family planning in the context of universal access to reproductive health as alluded to within the MDG framework. Thank you very much. Thank you.
No problem.
Thank you very much, Chair.
Thank you.
Chair.
Thank you. Yes, sir. Thank you.
Thank you.
Well done.
Thank you.
You're busy, huh?
Thanks, Fred.
Thank you.
Thanks, Mark.
Thank you.
Does you have a website?
Yes, I have a website.